Hi, this is Dr. Nick with the ECG Academy, and this chapter is going to be about atrial tachycardia with AV block. So we're going on to the next section here. Atrial tachycardia with block. It's a common problem, and you see it because of the way the AV node behaves. Remember that the AV node is not capable of rapid conduction, in part because the cells of the AV node depolarize because of calcium currents that run into the cells, and the action potential has a much slower upstroke than the sodium-dependent cells of the bundle branches and the Purkinje fibers. So the AV node behaves in such a way that if the atrial rate is excessively rapid, the AV node will fail to conduct all those impulses. We've seen something like this when it comes to non-conducted PACs. So if the atrial rate reaches a certain point, the AV node will not be able to let those impulses through on a one-to-one basis. And you'll start to see AV block occur by virtue of the rapid atrial rate. So atrial tachycardia with block is a very common diagnosis, and it's based on the way the AV node behaves when the atrial rate gets too fast. Now, it doesn't matter if you have an atrial tachycardia that's due to reentry, or if you have an ectopic focus that's firing rapidly. If they're above whatever rate the AV node is capable of conducting, then you'll encounter some degree of AV block, and we'll show you different presentations of this. So here's an example of an ECG. It's a 12 lead, and as you scan across, you look at the forest first, you'll notice that there seems to be some kind of irregularity, but there's a regular pattern to it, so you could call it regularly irregular. Specifically, I see groups of 4 QRS complexes followed by a pause, 4 QRSs and a pause, and so you have group beating. Each group is 4 QRSs in duration. Now, when you hear group beating, you should think AV block. You have to start to think Wenke back, because type 1 second degree AV block often presents with group beating. And I tell people when you see group beating, the first thing you have to do is look for P waves and see if you have AV block going on. If we scan this cardiogram, where's the best place to look for P waves? Well, I think the best place to look for P waves is in the little pause here, because when you have a period where there are no QRSs, it gives you a good chance to look for P waves. And I would say that this is one right here. Let's look at some other leads. During the pause, indeed, you have P waves here, which you see in another lead. And in fact, you have one here in lead 1. So at the end of each pause, there appears to be a P wave that conducts to the QRS complex with a borderline PR interval. It's close to 200 milliseconds. But look at the P wave morphology. It's up a little bit in 1, but you notice it's negative in AVF. In fact, 2, 3, and AVF are all negative. And so this P wave is originating from somewhere in the low part of the atrium and traveling up towards the head. So this is clearly some kind of atrial arrhythmia. It's not sinus. The trick is to try to figure out where the rest of the P waves are. So if you kind of scan in between, I hope that you would actually notice that this very sharp deflection here, midway between the two beats, is the next P wave. And if you kind of scan across, you see another one here, and then one that's even here. Now, what you should notice is that the relationship between the QRS complex and the subsequent P wave is changing. Notice that this R to P interval is longer, and then the P comes a little bit earlier, and then the P comes even earlier still. The relationship between the P's and the QRSs are changing. If you look at the PR interval, in fact, you can see the PR is getting longer, and then longer still. Now, the question is, are these P waves regular? Because if they are, then we are looking at type 1 second degree AV block. So let's pull out our calipers. Now let's move our calipers around, and if you put it on the first P wave, and then I've set it up so that you are on the next P wave. Now let's march them on through, and you can see this P wave occurs at the same interval. It's on time. And this P wave seems to be on time. And if you keep on moving it, you see this negative deflection here. And if you put your calipers, you see that this occurs on time as well. So the P to P interval is regular. The rate, if we put the calipers on a heavy line, is about 120 beats per minute. So you have this ectopic atrial tachycardia at 120 beats per minute, and the PRs are getting longer, and then this P wave right here fails to conduct, And then the next P wave occurs on time and conducts with the shortest PR of the whole cycle. So the diagnosis here, we know it's not sinus. It has to be atrial tachycardia with block. Now, what kind of block? We can call it winky back. Some people will call it type 1 second degree. Well, what's the ratio between the P's and the QRSs? Remember, the second number of the ratio is the number of QRSs, and there's always going to be one more P wave. So since there are 4 QRSs, we know that this is 5-4 conduction. So that's the ratio, the number of P waves to the number of QRSs, 5-4. So this is atrial tachycardia with block, PAT with block, however you want to call it. But you've got to be able to look for these P waves, map them out, determine the relationship between the P's and the QRSs. Notice the P's were coming earlier and earlier in the R to R interval, and that's because the PR was getting longer. And then this one clearly occurs on time, and it fails to conduct to the ventricles. It's not a non-conducted atrial premature beat. That P wave occurred on time, and it blocked in the AV node. All right, so let's go on to the next example. Now, here's a rhythm strip, and I'll tell you time and time again during this course that you should never believe what you read. In other words, if you're looking at a rhythm strip and someone has written 3.6 second run of AFib, always check it yourself. Never believe what anybody else has written, because you're going to be the ECG expert. When we scan across, we do see this rapid, irregular rhythm here. I think everyone would agree that there does seem to be a P wave followed by the QRS complex with a PR interval that's at the maybe a little bit longer than normal, maybe 210 milliseconds or so. But this certainly seems to be a sinus beat that leads off this strip. And then all of a sudden you have these irregular rapid beats, and you're trying to figure out if there's a pattern to it. Maybe there is, maybe there isn't, but let's look at what the atrium is doing. Well, if we look at this R to R interval and we scan around, we see a nice T wave here, and then there's this sharp deflection right here. This would appear to precede this QRS complex. So this sharp signal, remember P waves have high frequency components to them as opposed to T waves. That sharp deflection is a P wave. I don't see any other P waves in here. And this conducts with a first degree AV block to the ventricles here. Now let's look at the next T wave, the T wave of this QRS complex. What does it look like? It certainly does not look like this T wave. It's got this really deep, sharp-looking squiggle. It's almost like a shark came by and took a bite out of it. And if I get rid of some of my annotations here, I think it's safe to say that this signal right here looks a lot like this signal right here. So sure enough, this is another P wave. And what's the rate? The rate's about 150 beats a minute. Now this conducts with a very long PR interval to this QRS complex. But you're getting a pattern here that you have a slightly longer PR, a very long PR, and if we try to map out, well, where would the next P wave occur? Look about 150 beats per minute or 200 milliseconds about, and you see a little bump here. That bump was not present here. If you compare the QRS complexes, you've got a little tiny spike at the beginning of the QRS, a little tiny spike here, but now you have a very large bump. That is the next P wave, or at least the beginning of the next P wave. And sure enough, it occurs on time. Now, if that's the next P wave, where's the QRS complex that follows it? There doesn't appear to be any. Well, let's keep looking at the P waves. Do they map out? Well, if you look another 400 milliseconds out, you see this signal, and then you see this signal, and then you see this one. You have to use your eyes and try to pick these signals out. And here's the next one, and the next one. And so what's happening is that you have this atrial tachycardia that's proceeding through the strip at a rate of about 150 beats per minute. Once I point these out to you, don't you notice that they're there? As soon as I sort of like put the dreaded arrow sign here, doesn't that jump right off the page at you? You say, oh my goodness, I should have seen that. How did I miss that? So what you have here is a run of atrial tachycardia at 150 beats per minute. But what's happening to the AV node is the AV node cannot keep up with it. The AV node is blocked up. You have a PR that gets longer. This one blocks. This one conducts with a fairly long PR. This one obviously didn't go anywhere because there's no QRS following it, so that blocked. This one conducted to this QRS. This one conducted to this QRS, and then this one blocks. So you have this weird kind of unusual winky back-ish kind of pattern. And then this is the last P wave of the tachycardia. Well, I guess it's kind of debatable whether there might be one buried in this QRS complex, but I don't think so. The P here is very wide. It's a wide P because obviously the patient has a lot of intra-atrial conduction delay. It takes a long, long time for this signal to get around the atrium, so the P wave is long in duration. And if it had started here, I think you'd probably see the tail end of it on this side of the QRS. So my feeling is that this is the last Mohican. This is the last P wave that conducts, and then the tachycardia stops. And you have no QRS after that. What you have is a compensatory pause until the next sinus beat kicks in and conducts at the sort of the baseline PR interval of about 220 milliseconds or so. And then you're back in sinus rhythm. So if I hadn't pointed those P's out, you might say, oh, look at that, a run of atrial fibrillation. Well, of course, we didn't cover atrial fibrillation in this course yet. We're going to do it in the next couple of sections. But atrial fibrillation would clearly not look like this. This is atrial tachycardia with AV block, and you should be able to recognize this if you take the time to look at the little details. Becoming an ECG expert means you have to carefully analyze these strips for the subtle details, but now that I've shown you what it looks like, and after you practice a few times, those little details will pop right off the page. You'll be able to pick those up right away. The last one I want to show you is another 12 lead, and it's very deceptive because when you first start to look at the QRS complexes, you see that they are clearly regular. They're kind of marching on through. And when you look at lead 2, you'd say, this looks like a nice P wave here. And it almost looks like just sinus rhythm with a first degree AV block because the PR is about maybe 260 milliseconds long. You'd say, okay, no big deal, sinus rhythm first degree AV block. And in fact, the cardiologist who read this ECG called it just that. But when you look at all the P waves, make sure that they're really sinus P waves. Remember, they should be up in AVF, and they should also be up in 1. But when you look at this P wave in 1, it looks kind of weird. It's very low in amplitude, it has a little double bump, and it really kind of doesn't look like a sinus P wave. Well, that's where you have to start looking at all the P waves. And when you look at V1, you see this kind of P wave-ish looking signal in front of the QRS. Well, you need to be able to ask yourself, what am I missing? Is this really just sinus with first degree, or is there something else? And I always teach people, when you see a P wave that doesn't look like a regular P wave, look in between the two P waves. And if you just look in between, what you'll see is a sharp little bump on the T here in lead V1, okay? And if you look at lead 1, you'll see the same sharp deflection on the T wave here. So what you're dealing with here is an atrial tachycardia with 2-to-1 conduction to the ventricles. It's harder to see the bumps in the other leads, but what I can show you here in lead 3, remember that this P wave is upright. This P wave is upright. If you look halfway between those P waves, look at this bump on the ST segment. ST segments aren't supposed to go up like that. ST segments are supposed to be flat. So that's a clue here that what you're dealing with is an atrial tachycardia with 2-to-1 conduction to the ventricles. So if the ventricular rate here, if I measure it 300, 150, 100, it's about 85 beats per minute or so. So the atrial rate must be twice that. So that's 170 beats per minute. So we have an atrial tachycardia at 170 beats per minute with 2-to-1 AV block, you can call it, or 2-to-1 AV conduction. Now, remember, I like the word conduction better than block because if a normal person's atrial rate suddenly got to 170, it would be very likely that the AV node would fail to conduct all those impulses. So that's why I prefer the term conduction, 2-to-1 AV conduction, because the word block makes you think there's something wrong with the AV node. And under these circumstances, the AV node would simply be exhibiting normal behavior. So now that you've seen a few examples of atrial tachycardia with block, we'll go on to the next chapter, which deals with atrial tachycardia and aberrant conduction. It's one of the most difficult ECG diagnoses to make, but I think it's the most fun. So for the ECG Academy, this is Dr. Nick. Thanks for watching.